Okay, so good afternoon, everyone. On behalf of the ENS section of Trauma Neurosurgery, me and my colleague Peter would like to welcome you to today's interesting webinar. And we are going to start now. The numbers are still popping up for the participants. So today we are going to have the webinar on ethics in neurotrauma, the ethical issues. And we are trying to explore that, are we operating on the right indications? So just to tell you a little bit brief about our webinar, at the very beginning, we'll come to know about the basics of the medical ethics, and later we'll go through the cranial and the spinal ethical issues, and we have very prominent speakers with us. Just some rules. So approximately 20 to 25 minutes for each talk. And at the end, we will have around 15 to 20 minutes to have a good discussion. And just to tell you, could you please put your question in Q&A, not in the chat box. We'll follow the Q&A and we'll try to answer the best. So Peter, it's your turn. Could you please introduce and go forward? Thank you.
Thank you. Thanks again from my side for the participants to listen to this webinar. And first, I'd like to ask Dr. Beata Laki, an assistant professor from the Department of Behavioral Sciences from the University of Pécs in Hungary, to give her talk about general description of medical ethics and aspects of it.
Thank you, Peter. Good afternoon, everybody. I try to share my screen. I have some slides for you. Yeah. Please. Can you see my presentation mode? Okay, thank you. I am Beata Laki, as Peter said, and I am a bioethicist and philosopher. So I try to focus on medical ethics from a general perspective, and it is my honor to give the introductory lecture at the webinar, which can give a frame of the following presentations. I think all of you have already met the definition and scientific field of medical ethics. And in this 25 minutes, I would like to just refresh your previous knowledge about it and trying to focus on and narrow the topic to those parts that are more relevant in neurotrauma. So I talk about the following content: medical ethics in general, the definition, the intention, why we use it, how we use it, why is it essential part of medical care. Then I would like to show an example for decision-making models that help us dive deeper into the medical ethics and the whole process, how we make decisions and collaborate with patients, and why is it necessary. And if we go beyond, from the moral theories, I just highlight one, the deontology, because of the nature of neurotrauma. It is more essential and suitable for solving and supporting the decision-making procedure and solving the moral issues in this field of medicine. And the next smaller but inevitable topic is basic principles of modern medical ethics, which give us a toolbar that help us trying to identify all of the essential parts of such a situation when a moral issue appears. And last but not least, the patient information and informed consent are in the center. And in mind, we can draw an arch as we go through these topics. At least this is my intention. And we build up the network of it that tries to create a safety toolbar and so environment to represent the needs and interests during the medical care. Okay, let's see. We start with medical ethics in general. It is a part of ethics within that normative ethics, applied ethics, and separated specific field of medical ethics. It involves examining a specific problem using values, facts, and logic to decide what the best course of action should be. It analyzes those questions which appears or can be morally unclear during the medical care. And furthermore, it prescribes the suitable behavior during the medical practice. The intention of rules of medical ethics is not just to tie our hands and set limits in order to punish or decrease efficiency, but it tries to help the medical care not only to cure the patient, but also to do it how it is good for them. And this is one of the main essence of the application of medical ethics and using this approach during the medical care. Here you can see a model, an example model that tries to serve to find, serve the aim. We can find these procedures, and when we want to use a decision-making model, trivially, it is necessary to identify and recognize that there appears a moral issue. Here you can see a flow chart of decision-making models that depicts an optional way of it. Depending on the nature of the situation, of course, we can find other examples as well. But this flow chart shows correctly that it is an extremely complex process, how we identify the moral issue, what kind of facts we try to recognize, and how we focus on the decision, what participants are in the situation. And it is as a summary of the decision-making process, but we have to be aware of the all of the participants who are the members of the medical staff, doctors, other nurses, etc., and the patient as well. And here we have to emphasize the collaborative physician-patient relationship, which can help to support the fluent and best practice of decision-making and the whole procedure. It is a patient-centered care, the collaborative physician-patient relationship, and these days it is in force, if I can say like that, and in practice, not just because it is the duty of the doctors, but it is in the interest of the patient. And it bases on respect on the patient and family viewpoints, preferences and values. And the competent patient is always involved in the decision-making procedures, since everybody has the right to bodily self-determination. And in case of neurotrauma, from my point of view, it is also essential, if it's not the most essential part of it. Okay, as I previously mentioned, I highlight one moral theory, the deontology, compared to consequentialism, which can be used for other moral issues or solving other moral issues. This is the so-called doctrine of duties. Deontology falls within the domain of moral theories that guide and assess our choices of what we ought to do. It is called as deontic theories. The most familiar forms of deontology, and also the forms presenting the greatest contrast to consequentialism, hold that some choices cannot be justified by their effects. that no matter how morally good their consequences are, some choices are morally forbidden. For such deontologists, what makes a choice right is its conformity with a moral norm. And not just one, but more solutions are possible and acceptable. The most important feature of deontology is not to break the moral rule. So it doesn't deal with directly and just with the consequences, the moral duties behind that, and not to break the moral rule. Using this is more effective in deciding individual ethical issues which don't affect on a group of people. And that is the reason why using this approach is more relevant than taking into consideration the consequentialist theory, which is completely in contrast with this one, since consequentialism measures the harm-benefit rate in order to ensure the most good solution for the most people who are affected. Yeah, and here we arrive one of the inevitable parts of medical ethics, the basic principles of it. The basic principles and moral principles to be considered in solving moral problems of modern medicine. With the help of these, we try to identify, formulate the moral issues and give answers to bioethical questions. And we will see that, or not see, we won't see, but we can experience during the practice that sometimes these are not enough for fulfilling the requirements of how we can solve a moral issue, but these are suitable for outlining it and trying to decrease the harmful consequences and harmful effects of certain appeared and identified situation. So sometimes it is just a toolbar, which is not completely suitable, but can help us to find the best way to find the best solution. The first is called as respect of autonomy. That means patients basically have the right to determine their own healthcare. People's autonomous decisions or actions cannot be restricted or impeded as long as they don't infringe on the autonomy of others. The respect of autonomy is equal to the right to self-determination within certain frames, as we can see it in the second statement as well. The second moral issues of moral principle of modern medical ethics is the do not harm, or primarily do not harm, primum non nocere, that is an unenforceable principle, since any medical intervention causes or at least threatens to cause some degree of harm. And that is why it is a kind of controversial basic principle, but we can see the essence of it. The physician must consider the rate of risk-benefit of an intervention, but it is up to the patient to decide whether he or she wants it or not. And here we can emphasize the physician-patient collaborative relationship again, and later I will bound it to or connect it to that, the patient information and the importance of communication in general. Doctors do not take responsibility according to the do not harm for the results, but they ensure that they perform the procedure with the utmost care. And this is the real and realistic essence of this do not harm principle. The third principle is the principle of beneficence. The term beneficence connotes acts or personal qualities of mercy, kindness, generosity, and charity. It is suggestive of altruism, love, humanity, and promoting the good of others. Generally, I agree that ordinary morality doesn't require beneficial acts that involve severe sacrifice or maximum altruism, such as physicians putting herself without protective drugs and equipment in a life-threatening condition in an epidemic in order to provide medical care. Unfortunately, we have examples and experiences connected to this principle of beneficence and the limits of it. COVID-19 is the best example for that. And here we can see that the protection of the doctor is more important, of course, than endangering their health and well-being. Well-being is another term, and I will mention it later as well. But connected to principle of beneficence, we can see the limits of it also. The hidden or implicit message of this principle is only that doctor can do good, who knows what for the patient is good, and to have this knowledge, the medical doctor has to know the preferences of the patient. And it depicts the importance of doctor-patient communication and its efficiency as well. Here we are drawing this arch, what I mentioned at the beginning of the presentation, because we have to deal with the patient, not from the paternalistic view, paternalistic role of the physician, but we have to collaborate with them. And if we know the patient better, we can recommend the most suitable options, interventions, cure for them. And without a good and effective communication, it is impossible. Okay, and the fourth basic principle of modern medical ethics is the principle of justice, the right to be treated equally and in some cases equal access to treatment. It can be found in many constitutions, but in actual practice, a number of different factors may influence actual access to treatment. This principle is used in medical practice mostly that time when they have to decide who gets the medical support treatment tool, when the resources are limited. And in case of, for example, lack of financial resources, it can be difficult to how to decide who gets the intervention, the treatment, the tool, and who should wait for the next opportunity. And in case of neurotrauma, I guess sometimes it can happen that you have to use the principle of justice. Okay, and one of the last slides and content what I would like to mention as a base or introductory part of medical ethics is the patient information and informed consent. These are strongly connected with each other and with the previously mentioned principles and the decision-making model and the medical ethics in general. If you would like to define the informed consent, it is called as a voluntary, free, and informed authorization by the patient to carry out the intervention planned by the doctor. It bases on equality and collaborative physician-patient relationship. The doctor involves the patient into the decision-making process, the competent patient, and it is not just formal but practical also. Patient's autonomy is taken into consideration. The patient makes the decisions and gives her his consent to the planned intervention, but with the knowledge of the possible risks, benefits, alternative interventions. And here we can see the essence of patient information. The application of the right of self-determination is the part of it, and it is the base of informed rejection too. And that is one of the reasons why the right, correct patient information is incredibly important, not just because informed consent, but because informed rejection as well. Doctors have to adjust to the patient's prior knowledge, enlighten them about the necessary information, and it is not allowed to deprive the patient from accurate information. Otherwise, we deprive them from rational decision-making. And with that, we can act against not just the law, but against the do not harm principle also. And this is one of the duties of medical care and doctors. And let me emphasize one document which is a useful and a good summary as the essence and the message of medical care. This is the Declaration of Geneva from 2017. This is the last or the freshest version of it. This is such a guideline that helps to follow the best practice in the interest of the patient, because the patient's role is to help those who need it without discrimination and in the name of beneficence. The discrimination and eliminating or avoiding it appears here in the fifth paragraph or statement of the declaration. And beyond this, all of the basic principles appear in this document. So this is a good summary of it also, but it is much more. Since it expresses that physicians' well-being is as much important as the patient's. And with this statement, it is visible that although the human resource is a part of this service, kind of service, the medical care, but they are not just tools. Here we can see that the physicians who are a part of the service is similar to the patients, because all of us are humans and we have to deal with each other similarly. And probably it can strengthen the physician-patient collaborative relationship as well, although the medical ethics and the moral, the basic principles of it are a guideline for medical doctors, how we should treat the patients, how we should inform them, how we can collaborate with them. And it's not an educational part in case of the patient, but it represents such a statement that tries to show that we are all the same and all equal, or we should be all equal. The essence of medical ethics is to give support and tools to handle the moral labyrinths of medical care, when we take into account the patient's preferences, also not just the physical facts and medical indication. Although doctors know what is the best procedure according to their medical knowledge, education, evidence-based information, but the patients know which one is the best for them, paying attention to their own quality of life, possible, acceptable consequences of the interventions, etc. If we communicate well and know the patient's value system, the moral dilemmas can be handled easier. So to sum up my thoughts, medical ethics gives a toolbar identifying, solving the possible moral issues, but the human factor is the main key to use it efficiently in order to cure the patients as it is the best for them. Thank you for your attention.
Thank you for the interesting presentation, and I'd like to ask Dr. Hossein to further moderate the presentations.
Thank you, Peter. So it's my honor to introduce Prof. Franco Servadei from Humanitas University and Research Hospital, Milano, Italy. And no need to introduce him, especially Prof. Servadei also served as the president of WFNS for quite a long time. And he improved the neurosurgical training and education, especially for the young neurosurgeons. And also would like to thank him to promote the global neurosurgery around the world. So, Prof, we are looking forward to hearing from you now.
Thank you, Ifti. Thank you, Peter. Thank you, everyone, for the invitation. I will just sharing my screen. Yeah. Okay. Can you see my screen? Okay, let's go. I will speak in 25 minutes about only one case. But this case represents the most common ethical problems we face in surgery for brain injury. The case deals with the patients who needs or not a decompression. Decompression is like a panacea from the old Greek word, meaning a cure for everything. Unfortunately, no, but it seems like. So I will speak about one case and I hope to raise a fruitful discussion. It's a male, 15 years old, bicycle driver without helmet, Glasgow coma score 3 on the scene and after stabilization, possibly one reacting pupil. So according to our law, is not brain death because some brainstem reflexes are still there with multiple fractures. This is the CT scan, which I think we all agree is a disaster. We do have brainstem hemorrhage. We have a contusion, large contusion, acute subdural, almost a book of traumatic neurosurgery. What do? We have in favor of surgery the 15 years, the pressure of the family wanted us to do something anyway, even in spite of the fact that we explained repeatedly that it could end in a very bad situation. So 15 years and one reacting pupil. Against, we have brainstem damage, clear on the CT scan, and the Glasgow 3. So what to decide? My colleague who was in duty called me, so if you want, you can blame me. We decided together and we did a large decompressive bone flap with hematoma evacuation, subdural, not the contusion. So this is called primary decompression. It's a decompression which is done together with hematoma evacuation. This is the CT scan after 10 days, brain still bulging, increasing hydrocephalus. Then we had all possible complications. The patient remained in persistent vegetative state. He developed an hydrocephalus, so we had to place a spinal drainage. Then we did the cranioplasty. Then we did a shunt, a programmable shunt. Then we had a bradycardia, so we have to move the pressure of the shunt in many times. So at the end, the patient died after 6 years of family misery. Luckily, we are in Europe, so there was no money loss for healthcare. But because we are in Europe, you can imagine this case in the States would have mean a terrible loss of money for more than one family. So clearly, what we did was in contrast with what already in 75 Cooper and Ranshoff wrote. The operation should be restricted to those patients who enter the hospital obtunded, but without demonstrable brainstem dysfunction, already in 75. And the paper was entitled, "At least early warning against neurosurgical and neurological disaster." So already in 75, there was a warning. So clearly we made the wrong decision. Are we guilty since we did not follow guidelines, strong recommendation, level 1 clinical trials, or even suggestions, as you have seen, from the 70s? So we are guilty because we didn't follow an advice who could help us in decision. We did the primary decompression, which is different from secondary decompression. What about primary decompression? Primary decompression is the decompression which is associated with, as we have done, an hematoma evacuation, like acute subdural hematoma. And the result of this study had been published this month, the month of April, in the New England Medical Journal, or even for a large contusion. So we can do what we call it a primary hematoma evacuation and decompression. This is the study which has been just published. Retrospectively, could this study help us in the decision, in the wrong decision we have taken? Question mark. This study shows that there is an equipoise, an equity between hematoma evacuation or hematoma evacuation plus decompression. So apparently the study is in favor of waiting and not decompressing the patient together with hematoma evacuation. But if we look at the study, then we have to do some consideration about our case. The patient age in our patient is 15 years. The patient age in the study is from 16 years, so it doesn't mean anything, 1 year of difference. We can include the patient in the study because he has a contusion plus a subdural hematoma. In the clinical randomized study, there is no mention about brainstem damage, but if you look at the addendum and you look at the description of the cases which were randomized are only the case in which the surgeon decided that replacing the bone flap was an option. Not for us, because we decided from the beginning that the patient needed a decompression. So this study in this particular patient cannot help a lot. What about the other studies about decompression? These are the studies about secondary decompression. And you see it here, the two famous studies, the DECRA and the Rescue ICP. I don't want to go into details in this study. The DECRA study is this study, diffuse injury, decompression if ICP was higher than 20 for more than 1 hour. We call it early decompression. The study was flat, did not demonstrate a superiority of decompressive craniectomy. Actually, standard of care was good. But look at this. In this study, which is an ethical issue, in this study, death, vegetative state, lower severe disability, and upper severe disability are together scored as bad results. Remember, because it will not be the same in other studies. So bad result is also an upper severe disability. We see it. Then this study was replicated in Pakistan, exactly the same study with opposite results. So it comes to us the knowledge that wherever we do the study can show different results. I mean, this study is the same inclusion criteria, everything is the same. Then we have the Rescue ICP study. We all know it is a delayed decompression as last tier therapy. Means whenever we finish all the possibility we have in our hands, then we use it. The study was done in almost many countries, but mainly in UK and other European countries, which is also important for the result of the study. And in this study, different from the other study, what is bad result was that vegetative state and lower severe disability, but let's say upper severe disability, differently from the other study, was considered a good result. Who is upper severe disability patient? A patient who is independent only at home. So the first ethical issue, a patient who is independent only at home is to be considered a good or a bad result. The group of Cambridge who was leading this study and the subsequent study thought, to my knowledge, also is a right approach, that when we do decompression, we do an extreme surgery. So a patient who is independent at home can be considered a good result. Which are the results of this study? As you see, mortality decreased by half, but morbidity increased by double in this study. At 6 months, there was no difference in outcomes between surgical and medical group. If we do a 12-month outcome, then there is a difference, meaning the surgical group is improving in good result, again, more than the non-surgical group. So we have to wait 12 months. These results are the same in every study on brain injury who is randomized. The results are improving in the surgical arm between 6 months, 12 months, and even 24 months. What does it mean? That we need a long chain of care. We need to cure hydrocephalus, to reconstruct the skull with the cranioplasty, to follow the patients for a long time, at least 1 year, if not 2 years. But how many countries in the world can pay for it? Only 6. Only 6 countries in the world have complete free rehabilitation for all the life. Other 12 countries have some limits, very small limits. Almost all of these countries are in Europe. And this study, 80% of the patients which were included in this study belong to 2 countries who had this possibility. So we have to look. The other issue, very important from the point of view of ethics, when do we do a decompression? As if you look at this paper published in the New England Journal of Medicine, in the star case of medical treatment of ICP, decompressive craniotomy comes at the top, at the end. But as you see in this study, already Nino Stocchetti and the Milano group in 2009, and our group in 2014, in Marseille in 2003, in Baltimore, just in the same years, 5% about of patients admitted with the severe head injuries are decompressed. All the others are treated medically with success. So a small minority of patients. If we look at this American paper published a few years ago, you see here that the number of patients decompressed among the group of severe head injuries was ranging between 75 and 44%. So huge difference. And you see the difference here. We had a meeting in New Orleans after the publication of the rescue ICP, and we asked the audience, did your indication for surgery increased or decreased after the publication of these 2 papers? And almost all the American neurosurgeons say increased. Almost all the European neurosurgeons say decreased. So the views before on one side or the other of the ocean are clearly different. Then the other question, and I'm going to 5 minutes to finish. Do the neurosurgeon know when to stop? Which is also an ethical question. Do we know, as we probably have done a mistake not stopping, but do we know when to stop? This is a patient who is 86 years old, under anticoagulants with a Glasgow 3 anisocoric. I don't think any one of us will dream of doing anything, but I did a course in San Diego and asked to 47 neurosurgeons, what do you want to do? And 60 said, I will reverse coagulation and operate, and 7 will also decompress. Or this is a case with in another hospital, 1 hour drive from neurosurgery, huge hematoma with also clot in the ventricles. And we asked at the ENS course in person, 2018, what do you want to do? And as you see, 65% of neurosurgeons in Europe wanted to transfer this patient. 2/3 of them wanted also to operate on this patient. This patient died half an hour after this CT scan. So the answer to this question is no. Many times we don't know how to stop. This is a key point, ethically speaking. And then we have the issues of age. Whenever we have a number of patients in Europe who are old, who are admitted for trauma with many comorbidities. So for us, Europeans, is a problem, because if we look at the clinical study, the inclusion criteria always end at 65 years. So again, we cannot use a clinical study to determine the limits of our surgery, because clinical study do not include these patients. There are quite a number of papers. This is a paper from Israel, which the conclusion is that decompression for elderly patients may be a futile treatment. Same conclusion in Italy, in Rome, a group from the Cattolica hospital in Rome, same conclusion. Our result to give rise to ethical question in relation to decompression over 65 years of age. So again, we don't have guidelines, but we have papers published about this. Then what about the guidelines we have? These are the last American guidelines, which only one sentence is enough. Neither DECRA or Rescue ICP, together or separately, provide definite evidence for or against the performance of decompression. So there are no clear guidelines about what to do. So we probably were not so guilty. The same is from the consensus conference we made in Cambridge. Again, we have suggestions, but in a case like the one I showed you, these suggestions are not very much helpful, unfortunately. What about outcome predictors? And I'm going to finish soon. You see, this is the same patient. It's one of our patients in 2 different prognostic tools who are in the web. One is crash and the other one is impact. Same patient, same description. If we look at the predictive model, you see that on the left, the possibility of an unfavorable outcome is 86%. On the right, same patient is 75%. Why? Because we know that the models are not very well calibrated. Whenever we go to a level of mortality where it's greater than 80%, then we do have a problem. As for our case, when we do surely have a limit of over 80%. So when we don't know what to do, what do? We invent. So this is a very nice paper saying self-fulfilling prophecies. So we predict ourselves an outcome that basically we don't have the possibility to predict carefully. And also, at the end, we have to consider what we call it the disability paradox. Many patients feel when they have a severe disability that they are much better than they really are, according to our scales. So we must be very careful This is the conclusion. Unfortunately, the conclusion is we made a mistake because we are confused. And this is a European Center TBI survey among European neurosurgeons. Do you do an early or a late decompression? 50-50. Basically, I don't know. And also the same difference in a recent published paper. So what we know is that across Europe, different centers are doing in different ways in the same patient. And as I'm trying to tell you, this is the result of a lack of clear guidelines, which can be an ethical approach to a disease like the one I showed you. I think the best sentence was written by Martin Smith, who is a neurointensivist in London. The decision to recommend that decompressive craniectomies must always be made, not only in the context of clinical indication, but also after social consideration of patients' individual preference and quality of life expectation, without the patient, because the patient is sick, is in coma, but with the families. So whenever we do have to deal with this patient, we have to consider always that we work together with intensivists and neurologists together. We make a common decision. We have to know the available postoperative research. I have shown you how important it is to follow up for a long time a surgical patient. We have to discuss it with the family. And the last thing, sometimes we have to stop, which is a very difficult. This is a painting of Tiziano Veselio called Noli Me Tangere, Don't Touch Me. And this patient, this particular painting is showing how difficult it is sometimes to stop, don't touch. So this is the main thing. We have to consider, do we have done all we could to control intracranial pressure? If not, we do it. If yes, then we consider decompression without too much knowledge of guidelines, consensus. At the moment, we don't have it. So we work together and we build up a decision. Thank you.
Yeah, thank you, Prof, for your excellent talk. I think we will have a discussion at the end. So now it's my pleasure to welcome Prof. Wilkopel. Prof. Wilkopel has been serving as a professor and chairman of the Department of Neurosurgery of Leiden University Medical Center. And besides this, he's also the chief editor of the ENS official journal, Brain and Spine, in conjunction with Eurospine. And we would like to thank Prof. Pearl to inspire us to become evidence-based surgical scientist and also to improve the craniocervical management around the world. So, Prof, it's your turn now.
Yeah, I tried to share something, but I have to allow. Wait a minute. Thank you very much. The hospital. Oh, look. So hopefully I can start now, share. Yeah. Do you see my screen? So this is already my last slide, but probably the most important slide. From epidemiological point of view, I want to look at prediction modeling. And the former speakers already talked about ethics and moral deliberations. But it's very difficult if we cannot predict what the outcome will be. And as most of you know, I have a spine history in research. As nurses, we also, besides trauma, we do a lot of spine surgery. And it's quite easy to predict outcomes with degenerative spine disease. It's also easy to predict outcome in brain tumor disease. But it's very difficult to predict outcome in neurotrauma, and especially brain trauma and spinal cord injury. So I will focus most of my presentation on cranial spinal trauma. Also, I have one case in which I think we did something wrong, and I think that everybody who's listening and recognizing some things, but frequently we step too much beyond that. So my goal is that we create awareness of that we have resulting human disability, but we have a very important role. It's modest, but it's an important role in modifying traumatic neurological diseases. But we sometimes need time to look what can happen after surgery or after critical care treatment, without feeling too guilty that something went wrong. So if we look from a European perspective, what Frank already told, it's very different from North America. It's also very difficult from Africa and Southeast Asia if you have different circumstances. So my personal view created also my view on neurotrauma itself. And I think that is the most important fact, that if you have your personal opinions and your life events in medical care, for us it's neurosurgery, for somebody else it's cardiac surgery, but for neurosurgery it is completely different from other disciplines. And this is an instance, one of my cases, when I was very young. I operated upon this patient in 1996. He was a 20-year-old student who had a very severe brain trauma with acute subhematoma, brain contusions, very aggressive treatment. He recovered quite well after surgery, after 1 year with rehabilitation medicine. He even wrote a website about it and said, well, I'm very happy with my life, and I thank the hospital and the doctors for the good treatment. When I started looking at outcomes 6 to 7 years ago, or already 8 years ago, together with one of my PhD students, I visited all the patients who said, I have a good outcome. And I also visited this young guy who at that moment was nearly 20 years older. And I didn't see a very happy guy. I did see a happy guy who was happy with himself, but he didn't have friends anymore. He lived with his parents. He had a lot of insults, epileptic fits, and he lost all friends and he couldn't get a job. Shortly after my visit, my PhD student and myself, we looked at each other at the car. And is this our good outcome? If this is upper good recovery, well, is this good outcome? So we thought it might not be a good outcome. 1 year later, this kid died, or the man died. So he had 20 years, and this is his remembrance. This is in Dutch, so he cannot read it. But his parents said, well, Wilco, he had a happy life before surgery and before his trauma, but he also had a very happy and useful life after the trauma and surgery. So we as healthy physicians looking at the outcome, we're looking differently at that. So when he died, his parents said, well, he had a life before, then he had the trauma, and then a life thereafter. So then we started thinking, how can that be? What is a good outcome? And is there a favorable or unfavorable outcome? Franco just showed you the outcome scale, which is mostly dichotomized. And dichotomizing of an outcome scale might be very difficult because it's not showing the essence of life. So we have, especially in high C-spine injury, spinal cord injury, and also brainstem injury, we have this kind of disability paradox. And those who are interested, there's a beautiful paper by Bodenhammer in 1983. And it says that there's a huge difference between the desire of patients to go on living and the perception of that desire by the caregivers, the former being higher. So patients with brain injury or spinal cord injury, after the recovery and or after rehabilitation, they perceive their ability to live and their happiness better, as a better quality of life than parents, brothers, sisters, and children. So how to deal with that? Because Beata showed in the first presentation that we have to look at the preferences of our patients, take that into account, and also that we as doctors knows probably what is best for our patients. But if we do not know what a good quality of life is, what can we say about that? So when we think about ethics in neurosurgery and neurotrauma, the ethics is thinking about doing good. We want to do the good thing. The reason why most of you became neurosurgeons or young neurosurgeons or trainees, you want to treat your patients the best way and that the outcome is good. But the central question is, what is good in which context? And that also different between communities and cultures. So I think that, and I saw also written a lot about it, ethics is a reflection of the good moral and looks for the moral boundaries. But again, what is good in the Netherlands might be different from Italy, from the UK, from North America, or from Africa, where I recently was. So I can treat about the most modern technique of spinal cord injury in C-spine in urgent surgery. But if you don't have rehabilitation medicine problem, why should you? And that's difficult to access. So if you look at the classics of Plato and Aristotle, you say, well, they have written down what is a good life. So the best books are, I think, in my opinion, from Aristotle. And if you look at his Ethica and you look at all the values of life, then take that into account and get it to our patients. Then we have to say, well, if I treat this patient, will this patient, after the treatment, be a person, not a patient anymore, but a person who has pleasure, who can cooperate, have friendships, can love, can cry about the things in life. So looking at that, it's different between countries and even within countries between hospitals. So this PhD student where I talked about is Jeroen van Dijk. He did his PhD on ethics and economics in brain trauma, and he led a discussion between two hospitals in my country. So it was Leiden Rotterdam versus Nijmegen and Tilburg. So a very small country, huge differences. Me being a very aggressive neurosurgeon, aggressive meaning that I do a lot of surgery to let the people survive, and my colleague, also a scientific neurosurgeon, less aggressive, especially in the elderly and pediatric ones. So if you look at that, you have to think about what is the treatment protocol of severe TBI and severe high C-spine injury in your department. And normally we discuss that during the ENS courses or WFNS courses. And we say, well, what's the code of conduct? Do you discuss that? Is that never noticed, or don't you think about it? So if you don't think about it, then try next week or tomorrow to discuss that with your peers. Is it decided by your boss, chair, or supervisor? So who is deciding what to do, treat or not treat, or withdraw treatment after surgery? Do everything what is technically feasible, which is kind of culture in my clinics. And last but not least, and especially in the Netherlands, I'll come back to that later, do we decide to let the patient go, let him, her, or never let go? And what about organ transplantation after this decision making? Are we as neurosurgeons the people who have to ask the question after brain death has occurred, or we stop the treatment, that organ transplantation should be asked by the treating physicians, which is something which I find very, very difficult. And I don't like to talk about it in our group without being a treating physician. It's much more easier to ask that question. So there's a book about it. It's written by a nurse, and this is a very good book. It is a little bit difficult to read for the beginners, but it looks at the moral boundaries. It looks also at the moral boundaries. If you read the book, you can look at yourself. What's your own moral boundary? Where can I cross the threshold And if I am a trainee or a young neurosurgeon, and my boss decides that treatment should be done in this brain trauma or spinal cord injury patient, how do I feel about it? And I just show you a case in which I think the same like Franco said, where I think we as a department did something not very good. We did something wrong. So listen and look without prejudice. Also a child, 3 years of age, high energy trauma. Father was falling asleep behind the steering wheel, and he had a frontal collision, and the boy, 3 years of age, was propelled out of the trauma, and he was reanimated shortly. I won't go into details, but he came inside the hospital in a very bad neurological shape. He still had reacting pupils. That's important. He had no reflexes and no Babinski's. At that moment, he was hemodynamically stable. Brother had a small injury. Mother had a severe injury, but she was stable. The father had no injury beside the mental injury because he was falling asleep behind the steering wheel. So it's difficult to discuss with a mother severely injured and a father who is feeling very guilty that he caused the trauma and the injury. Well, the first CT scan, besides a full brain, we don't see anything very abnormal. And that's also risky because if we don't see anything and the patient is not doing anything, then prognosis might be bad. The CT scan of the craniocervical spine looked in first normal, but looking back at that, you can say the distance between the occiput and the cervical spine might be large, but I don't think it's large. The radiology was saying that, looking with retrospect. So those were the CT scan and the MRI, or the CT scan of the brain, and also of the C-spine and T-spine. Besides the brain trauma or spinal cord injury, he had a compartment syndrome to the lower left leg and a hemotothorax. So he went directly to the R to have thoracic drains, ICP monitoring, because we didn't know where to look at. He had a very regular ICP, 11. And he had a decompression of his compartment syndrome. That is Saturday evening. He went to the pediatric ICU, but because we couldn't explain the neurological deficit, we did an MRI of the brain and the C-spine. And then we were shocked, because in the cranial cervical area and also in the upper thoracic area, but this is the most important fact, there was a subdural hematoma in the cranial cervical junction. So normally we would have a discussion group, and I would ask all the people what to do. And when we do that during the ANS training course, we hear all different opinions from different countries. And it's nice to see that, although it is a very severe case. So everybody's doing something. If somebody wouldn't treat, others would treat and treat a very long period. So there are different solutions. You can do a maximal intensive care treatment and be conservatively with surgery, to do a surgical intervention. And what kind of surgical intervention? To decompress or do decompression and fixation, or stop the treatment and let the child die. And the latter is in most countries won't be discussed. In the Netherlands, it is discussed by the ICU doctors. So it was middle of the night, so he was already a few hours within the hospital, probably already a little bit late. So during the examination, it looked like he was responsive with opening of his eyes, but there was no reaction of arms and legs. No high ICP, and we did see no spontaneous motor reaction, but a triple response. So what to do or not to do? So in our clinic, what we say, we do treat maximal in acute phase. So I won't discuss it here because it's difficult by Zoom. So we decide, well, there's a flexion extension trauma, high energy trauma, and possible post-anoxic encephalopathy. So we had to discuss, and we had a more deliberation shortly because we didn't have much time with the balance between the benefits surgery and treatment versus a possible lifelong suffering. But this possible lifelong suffering, do we know that in the acute phase? Can we say that based on this MRI? So we had this meeting and it was decided to do decompress and to do a craniocervical fixation together with T2, T3 decompression and fixation. So the fixation was done, no complications during surgery, hemodynamic stable. Following day, no difference compared to pre-operative treatment. Day 3, there was no spontaneous breathing, there was no sensory reaction and no motor reaction, but the kid had his eyes open and looked coherent. He closed his eyes on command. He follows the toys with his eyes, and he had tears in his eyes when he did see his brother. So we have a pediatric case with probably a normal brain function, but with a very severe high cervical spine injury. So at that moment, and we're talking about 6 to 7 years ago, it was decided within this group that there was an irreversible craniocervical spinal cord brainstem damage. And in 3 days, no recovery. And the brain, supraforamen and supratentorial, looked intact. No anoxic damage. So do we have to continue treatment? Yes or no? And I think that most of you would continue treatment. So what would you do is normal the discussion. We did do an MRI if the work was done properly and if the brainstem looked severely damaged. And again, it was 6 to 7 years ago. And the radiologist at that moment said, well, we see syngeal changes at the T2 level and also at several levels. So this is irreversible. Was he allowed to say that? Well, at that moment, probably, but currently we do know that these kinds of changes can change, especially in pediatric case. But the decision within our hospital, within our group, was to decide that the life wouldn't be worth living on a ventilator for the rest of his life. So the kid was given some more few days, and we talked to the parents. It's very difficult, again, to talk with the parents about the decision making, but the kid died after 6 days. So if we look afterwards, looking at this case, and especially if you look at other small kids, that in the Netherlands and in some other countries, this is a day-to-day discussion, also in neonates with trauma. In most other countries, it's not allowed to stop treatment. So it's also very important. And did we make the right decision or did we do something wrong? Well, I think we did something wrong. We had to wait much more longer in pediatric cases. Recently, we also, 1 year ago, we saw a case of 1 year of age, similar trauma, and there were some possibilities of recovery. So we looked at our own moral boundaries and we changed that. And we talk about it. And when we talk, who are we? Our department, our country, or global neurotraumatologists, the ENS, the WFNS, and AANS. So we need to talk more discussion about that. So it's very difficult in acute phase. In this acute stadium, you have to decide yes or no. And as neurosurgeons, you are all trained to decide acutely. Don't doubt. And currently, we need to doubt. In the past, with an acute subdural hematoma, I said, when doubt, take it out. And now I say, when doubt, don't take it out. Think a little bit more clearly and wait a little bit. So I won't repeat this one because Franco already told about these severe brain traumas. But again, where I started with, can we predict it? Or are we still looking as a gypsy and forecast the outcome to our neurocritical care doctors? So Franco already presented this study, so I won't repeat it. And I discussed it with Peter. So this is a study. These are the evidence-based data. Very important. If I treat my own patients, and put them herein. So I have similar patients with the same variables in starting of the trauma. Dying before surgery was even performed, dying after 8-9 days, full treatment, acute subtrauma, persistent vegetative, minimal conscious state, died 7 years after trauma. The boy, I told you in the beginning, might have a good outcome compared to his parents, following his parents. And this lady had the same variables as this lady, and she had a very good outcome. And these are the cases we want for our patients. We want this outcome for our patients. So for the next 5 to 10 years, we need to combine ethics and moral boundaries with predicting the outcome in an early stage, in a neurocritical care stage, not in the first 24 hours, but in the first few days, we need to decide. And then I come to my final slide. There's nothing good or wrong, but what is probably not good overvalued is our estimation of a good outcome or a favorable outcome versus an unfavorable outcome. That's very difficult. And I would say, all of you, please go, when you are in a department, ask your chiefs or yourself, what is my own moral deliberation? What is my ethical value within my country? And when you travel from country to country, remember that if you go from South Europe to Northern Europe, that the ethics and the moral deliberation might be quite different. And don't be shocked by it. Because if you are shocked by it, then you don't recognize that there's a difference in culture. And we recognize that. Thank you very much.
If your microphone.
Okay, thanks, Prof. And thank you, Prof, for the great talk. Yes, so Peter, would you like to go for the question and answers?
Well, we have two questions here. One is that is going to be a difference made by artificial intelligence in decision making, and do you think it's gonna make a difference in how we are following guidelines and so on, using the counting motor of the artificial intelligence?
I would answer the question if I can.
Please.
Okay, thank you. Artificial intelligence have a huge potential because of high data processing capacity, and that's the reason why we will use and involve them into decision-making processes. But I don't think that we will let it do the final decisions because the human control is essential, and we have to keep this control. So it will have an influence. It will have an effect on this surgical decision making processes. But in general, because we have to use the potential from it, and we have to have benefits from it. But I don't think that we can eliminate, or we want to eliminate, the human part of it. It's true that it reduces the risk of human error in general. This is the same in case of autonomous vehicles. We try to reduce accidents as well, but the human control is necessary. So we have to stay cautious and keep the control. I hope I answered the question, but if you have anything else, just tell it to me. Thank you.
Thanks. Do you have anything to add to it?
Well, I think the two database I showed you, the predictors, so-called, the impact and the crash, are already a sort of artificial intelligence answer, because each of them contains more than 20,000 cases, which are summarized in a way in which we can make a prediction. And as I told you, we are not able to do it. So already we have an initial form of available artificial intelligence helping us, but not in helping us at the final decision, as Vilko said. The acute decision is made based on many factors, and the artificial intelligence can help us in one or two. The others are in the hands of doctors. The easiest way at the moment that I have seen traveling, it's that we have to know that we don't know, which is the first step to, as Vilko said, make a common decision among all those one who are curing the patients and the families. We don't have to be strict, as if you see the Vilko knows it, the last paper on withdrawal of care in Europe, made by the data of the center TBI, there are countries where withdrawal of care is 0, and countries where withdrawal of care is 91%. So the difference is huge. When we were doing a course in India, we asked, do you want to do an extreme decompression to save the life of a patient who cannot be cured? Because in India, there is no follow-up, no rehabilitation, nothing. And they say, yes, in our culture, having someone alive in the family makes a huge difference. So I believe these factors are important. We cannot copy each other. We have to find a way to do it properly in our house.
Yeah, and I agree with completely, and also with both of Beat and Franco. And to be honest, when we started CENT-TBI, already started 10 years ago, the ideas, the thinking that was earlier. And I had a lot of hope on artificial intelligence. I thought, well, this is the world of big data. And you probably, most of you don't know, but before studying medicine, I wanted to do mathematics. So, well, this is the world of brain trauma. And my former professor was Professor Braakman. Most of you don't know him, but he was a very old professor in Rotterdam. And he was my first trainer. And I said, I want to do brain trauma research. I want to look at evidence-based data and brain trauma research. And he worked together with Glasgow, and I think Franco also knows him. And I said, I want this. And then in 2013, so many years later, we get the chance of CENT-TBI, TRACK-TBI, in between the group in Cambridge of Angelos and Peter were doing these RCTs. So this, I think, the next 10 years, we will start with artificial intelligence. We will predict the outcomes. We are not able, even with the most difficult, sophisticated programs like R, which Thomas van Essen together with Hester looked at CENT-TBI data. It's so difficult. And even the interpretation of those data, it is personal values. And I think that the personal values are important, and properly in the future artificial intelligence, if you have more data than 100,000, 200,000 patients, then you have to look only at the big data within your own culture and country, because it is different. And I always thought that, for instance, my second home country, because I was on holiday, is Italy. If I talk to my Italian colleagues, we have a completely different opinion about treatment. So how can we use the data of Italy in the Netherlands and vice versa? No way.
Thank you. Bart put forward an interesting question. He's writing that in their own research, they found only poor relation between functional outcome and quality of life after TBI. So would you agree that quality of life is what we aim for, but as physicians, we only have impact on functional outcome, which is a different thing?
Yeah, may I answer first and then the others?
Sure, yeah.
Because
ahead,
if
please.
I look at, we had a long discussion in Cambridge about outcomes a few years ago before COVID. in severe brain trauma, not C-spine injury, because C-spine injury, your brain is intact, but in severe brain trauma, I suspect that patients who are after that people will have a second identity, a different identity. And it's more on the philosophical field if we only improve outcome in a functional way, or can we also improve the identity or decide for them? So I don't know what Bart himself thinks. What do you think, Franco and Beat? Beat, what do you think?
Actually, I totally agree with you. Yeah, because of the nature of this case or situation in general. Yeah.
Well, as already Wilco said, there's a long discussion about the value of outcome scales as compared to the quality of life. It's a 30 years old discussion. But unfortunately, we have been able only to add the quality of life scales, not to eliminate as you have seen, all of our studies are based on the Glasgow outcome scale with all the spectrums of difference that I've shown today. Ethically speaking, what is a patient who is autonomous only at home, as I've shown you before? Maybe the quality of life scales can help us to define better this patient and if it's worth to live or not, and in which country. I think this is the issue. When we plan studies, having a secondary follow-up with quality of life scale, I think as Wilco knows from the Center at TBI, as we have done, it's a mandatory now. So we have a primary endpoint who are based on functional scales, and the secondary endpoint is the quality of life scales. Combining them together will means to know better the outcome, but we not solve our issue, what to do in the first 2-3 days after injuries, which is the topic of today. Which decision should we take?
Yeah. I think also that Bart already knows. I was very busy with the European grant submission for a commission which is called Synergy, in which medical disciplines can work together with other disciplines. So, and then you come in the social demographic sciences, and that's a different language. I'm now trying to talk with them, and that's very good. They are interested, and then probably in the future we have to measure that. It is possible to measure that. We are not used to that in medical sciences, but in the philosophical sciences and social sciences, they are used to it. So if we can combine that and combine the efforts, then Bart, I think that we are able to look more into detail. What is the added value for the life of a patient? And the other question is it very important or dangerous if somebody has a different identity after trauma, which is a philosophical question.
Thank you. Ifti, do you have anything to add to it, or do you have any questions?
Probably I have an open question for all of you. So like in the UK or in the EU, we have protocol, we are following the randomized clinical trials and everything. But like one of the main pillars, as Beat also said, that do not harm. So our neurosurgical training, during our training, if we want to do something new, or if you want to try something new, like Prof, like in case of DC now, in different part of the world, people are talking about cystinotomy, hinge craniotomy, but we do not want to harm our patient. But in many settings, it's probably not also possible to do a randomized clinical trial. So how should we proceed? Like if we want to have a new approach of surgery, so how should we develop the evidence then?
Very good question. It is a key question for the future. I believe much more than what we are doing now in the Western countries, because having high-level data from countries where trauma is an endemic disease is extremely important. We are working on this. First of all, sometimes we think we cannot do what we can do. Remember that in the Rescue SDH study, the first enrollment was Bangalore in India, with almost 38% of all patients enrolled. And to give you the figures, all the UK centers together, meaning 24, enrolled the same number of patients as one center in India. So if we are able to deal with centers in these countries who can enroll patients according to our rules, that's good. The question about cystinotomy or hinge craniectomy, if you look, as you know, if you look at Facebook, is becoming a religion. It's like I believe in it or I don't believe. You know, we have written an editorial saying we need more evidence before it can become, let's say, a standard of treatment. And the question is, the randomization in the 3 studies about cystinotomy were done based on the availability of a vascular surgeon on duty, which obviously cannot be the randomization. So I believe we have to help the people who is there, who can work with us, we have the instruments, we have the methodology, we have everything, and adapt the methodology to them. I give you an example. The UK study, the NIOS study, the study done in together in Cambridge, the endpoint was Glasgow Outcome Scale on discharge, which is a nonsense from what I've shown you today, but is a sense because it's the only thing you can do in these countries. So we have to put our efforts and knowledge to help the people to build up and not to go to Facebook and say, I don't care about scientific papers. I don't care about guidelines. Cystinotomy works and is my religion. This is wrong. But wherever you go in the world, I've been in South America, you have been in China, they're all saying the same. Our community does not accept a very good technique, which is wrong. We only want to find a way to show that it works or not. But it's difficult to understand.
Thank you, Prof. It's very clear. Anything from Prof. Bill?
Well, I have the same opinion, but having said that, we now have the difficulty to prove that one of the oldest surgeries where is in the world, if is there any positive evidence for that. So I was trained when doubt, take it out, and do decompressive craniectomy, and everything is shaking now. So I don't know anymore, but indeed, new techniques, and especially very invasive techniques, where we don't know and its added value should not be done. And I think we should help those people in countries where there's a lot of discussion about it to do proper studies, and what's already said, do it like we should do. And remember that 30 to 40 years ago, neurosurgeons were not randomizing in our countries either. So why shouldn't we globally look at that and help each other in that? Not as in a paternalistic view, but to do it, introduce evidence-based neurosurgery in brain trauma and spinal cord injury. Yeah.
Yep, thank you.
And I can totally agree with both of you, because the nature of this this field of medicine is extremely severe. And if we do something new, try something new, it can have a result as a dead patient, and it's not a game. That's the reason why we have to measure the harm benefit rate and don't risk more than it is in general with general interventions. So it's the scientific progress is necessary, but we we will pay the price, and we are not allowed to pay the price with human lives. So,
Yeah.
thank you.
May I add something, Ifti? Because it is a very interesting question what you say. We had a huge discussion with our ethicist people in my country, and they say, well, neurosurgeons are thinking they stand above God, and they call it neurosurgical exceptionalism. So if neurosurgeons think that a new intervention will help for the good without evidence, then we have to be critical on ourselves and discuss it with other disciplines like medical ethicists. That's the reason why we have philosophers and medical ethicists. So thank you for this very great question. And also both of you, you and Peter and the whole trauma committee for this beautiful topic for a conference.
You are very welcome, and thanks to all of you for the great talks. Peter?
Yeah, thank you very much for contributing to this webinar. And we had above 60 participants, so I guess it was quite of interest to everyone. Thanks again for being online and also available for questions as well.
Thank you.
Bye.
Thanks.
Bye.
Thank you, everyone.
Thank you.
Have
Bye.
a good spring. Bye.
Thank you.
Bye.
Bye.